I'll now request Dr. Ragav to take up the topic of Dr. Tityal, and that is posterior polar cataract. Ragav has been with us for last several years, has been a great academic help, as also in research. He helped in the silk research, etc. He'll be talking about posterior polar cataracts. Ragav.
Thank you, sir, for this opportunity, for giving me. I have very huge shoes to fill for Tityal, sir, but I will try and just give you a brief overview how to manage posterior polar cataracts with the femto laser. So we all know that yes, whenever we as clinicians in the OPD are faced with such an image on the slit lamp, we know what we are in for. We cannot predict how the patient is going to behave, how this cataract is going to behave, and there are more chances than not that the posterior capsule will give way. So how do we as surgeons prepare ourselves? So we should know that whenever we have a posterior polar cataract, that there are certain things which we have to keep in mind. One is that yes, there will be a pre-existing posterior capsular weakness. No matter how much we try, there can be a chance that the posterior capsule does give way and we have to play with the vitreous. The femto laser can offer some advantages, the most important being pneumodelineation. That is the femto laser, that is the air bubbles that are created. It gives a clean cleavage and thus helping us to eliminate the need for any hydro procedures. And once that is done, the femto can also help us in softening the nucleus. Therefore, we can use less ultrasonic power. So points we have to keep in mind, yes, there should be a closed, stable chamber. We have to use low fluidics as for any posterior polar cataract. Use the AIOC, which I'm going to show you how. And the perfect rexis is very important. Yes, if something does go wrong, if you do have a good sulcus, you can always place a 3-piece lens. Careful or no hydro procedures. And yes, the advantage of an epinuclear cushion. So if you see, this is an image of how the posterior polar cataract looks like on the AIOC. So if you see that the lower part, that is where shows that because of the density of the posterior polar, we cannot see the base or the posterior capsule. So the high definition AIOC, it also has customizable offsets, which I will show you with the video. So if you see this case, you see these 3 markers. What we are doing is we are essentially just raising the posterior offset. That is, the femto laser can fire at about 1,000 micron distance from the posterior capsule, so that the posterior capsule is not at all troubled, and during phacoemulsification there will be less turbulences. So till now, many papers have been published to show that the AIOC can give us the state of the posterior pole, but none of the papers have till now been used to show that it can be used as a safety tool. So our group has done extensive work on posterior polar cataracts, showing that how the femtosecond laser can be used as a safety tool. So this is a case where we use the femto laser in a posterior polar cataract. Once the eye is docked, you can see in this image, if you see that this part, the green arrow showing that because of density of the posterior polar cataract, the posterior pole is not clearly visible. And because of that, we can be very, very sure that yes, there can be complications during the cataract surgery. So what we are now doing is we are raising the offset, the red arrow you see. So now this is the line where the laser will fire and not at the posterior capsule. So yes, once the laser fires, this is the intraoperative image. As a normal cataract surgery will proceed, we try and do a closed chamber phacoemulsification with low fluidics. Once the nucleus is removed, again, we try not to do any hydro procedures. If at all you have to do maybe hydrodelineation, but no dissection whatsoever. But in a femto laser, what we are trying to do is no hydro procedure at all. Because of the thick epinuclear cushion, we are going to protect our posterior capsule. So in this case, once the nucleus is disassembled and it is emulsified, we go in for a very slow epinuclear removal. And once we have to do very slow, and of course we have to always insert visco before we take out our instruments. So in this case, we were able to easily put in a 3-piece lens in the bag. Now I'll show you a bit more complicated case. In this case, you can see on the slit lamp itself, we can see an end-to-end discontinuity in the posterior capsule. You see this? So we know that no matter how much we try, there is going to be a discontinuity during surgery. So we do have a VR surgeon ready. So again, in this case, you see that this is where the posterior pole is, and this is the discontinuity in the posterior capsule. So now what we are going to do is we are going to dock, and this purple line we're going to increase to about 1000 microns from the posterior capsule, so that the laser will now fire at this level. What that essentially is doing is giving us a good and thick epinuclear cushion that acts as a new posterior capsule. So I will show it to you a bit more in detail. So now once the patient is on table, if you see this image on the right, so this is the microscope integrated ASO. So it is showing us that the posterior capsule, of course, there is a discontinuity, but what we've done is with the offset, we have a thick epinuclear cushion here. So all the turbulences are going to happen in this area now, and our posterior capsule is pretty safe. So we can go ahead and do our phacoemulsification as routine, keeping in mind all the points for a posterior polar cataract. And now again, once the cortex once there is an only epinuclear cushion, we do an ASOCT, and you can see very, very clearly this thick 1000 micron epinuclear cushion is protecting a posterior capsule, and it acts as a new posterior capsule. So at this stage till now, the major complication has been avoided. We cannot have a nucleus drop now. So now we start doing a very slow aspiration. Yes, we try doing it, and yes, of course, there is a pole-to-pole discontinuity as we had expected. We did a very so if you see this image, very interesting image, you can see that there is a discontinuity in the posterior capsule, but there is a vitreous blob that is coming inside the capsular bag, but it is not discontinuous. That means the vitreous has not been damaged till now. Anterior hyaloid face is not damaged. So we go and put in a lens in the sulcus and close the eye. So this patient also did very well, and we gained 6/6 part on the first day itself. So we have also published this in the IGO, showing how a case of posterior polar cataract looks like in different imaging modalities. This is the slit lamp, this is the integrated OCT, this is this SWEPS OCT on the IOL master, and again this is the microscopic integrated OCT. So let me just specify the importance of a good rhexis. Once you have a good centered rhexis, you can place a 3-piece lens in the sulcus, and nuclear softening can decrease our phacoemulsification power, and hydrodissection may be not required at all because of the pneumodissection. The air bubbles that are made by the femto laser can help us cleave the cortex and give us a very clean epinuclear cushion. So the epinucleus acts as a shield, and it can always act like an airbag. So on the left you see a car which has no airbags, but on the right you see this car which has an airbag. So the epinucleus essentially is acting like an airbag and protecting you. So to conclude, the posterior polar cataract is a nightmare for no matter how experienced the surgeon, but the ASOCT can help you be prepared, if not do anything before the surgery, so that we know what we are going to be in for and maybe increase the safety. And the femtosecond laser is the way forward in managing a posterior polar cataract. Thank you.
Thank you very much, Dr. Ragav, for an excellent exposition on posterior polar cataract for discussion.